I introduce my co-chair, Professor Mark Emberton, and we move on tissue selective therapies for prostate cancer, established versus experimental. Of course, there will be a place, perhaps after this technique, for surgery, debate, and radiotherapy. Please, Mark.
So thank you very much. It's been a fantastic morning. Last night, over fondue and very excellent Swiss wine, we were discussing whether specialism today affords the protectionism that it used to. In other words, as treatments become easier, and as we don't need a license to administer them, as in radiotherapy, or don't need to train for 10 years to master a technique, because there are many masters of technique here, there's a democratization of who it is that can deliver treatments. And we've seen that happen in a lot of surgical specialties, and I'll illustrate just some of them. And I think we were discussing this last night, and I think in prostate cancer we're poised in such a position because of these technologies that are arising that can be driven by the new emerging specialties of interventional oncology, interventional radiology, and indeed others that may indeed be treating patients in the future. So that's not a warning or not meant to worry us, but it's just meant to alert us that that nothing stops progress. You saw this yesterday from Laurie Klotz. I'm showing it because he borrowed it from me. And this just shows that progress is inevitable. There's nothing any of us can do about it. And what's shocking about today is that progress happens very suddenly, often very unexpectedly, and then diffuses very, very quickly, often much more quickly than our studies and indeed our regulatory processes can keep up with. And just to illustrate that is just kind of changing perceptions and views. And not most of you, some of you can remember when partial nephrectomy was proposed. It was very, very controversial. People thought that you would get lots of local recurrences. People thought it would be impossible to follow up. Many of you probably contributed to those arguments. I was a resident seeing that. Same in breast surgery 40 years ago. And now the statement looks kind of almost stupid in its kind of naivety. And the same happens in prostate. So when we started proposing studies to treat selectively, in other words, to try and pursue the goal of preserving tissue, which is what we do in active surveillance, this is just an extension of that, the skepticism was very strong. Skepticism is an appropriate response to new theories, but that was only a couple of years ago. And just last year, the MRC, who fund $500 million a year of research in the UK, thought that our very small, very simple study of selective therapy versus non-selective therapy, of selective therapy, was one of the most interesting breakthroughs that they had seen over the last preceding 12 months. And this interval is a 2-year interval. This couldn't happen. This couldn't have happened many years ago. And this is the pace at which perceptions change. So the title I was given, and this is the claim that has been made against it. But interestingly, it's the same claim that some of you made against nerve-sparing radical prostatectomy. So that claim was linked to nerve-sparing radical prostatectomy not so long ago, and now, of course, we don't go there. So it's just fascinating to see how our skepticism very rapidly transforms into acceptance. I was debating with Laurie the other day at a meeting, and it's interesting, the two standards of care that I was debating against were active surveillance and robotic surgery, none of which have developed with a randomized trial, and both of which, just a few years ago, were extremely controversial. So it is fascinating to see how things go. So this pursuit of tissue preservation, I think, is probably a laudable one. I think it's probably the direction of travel. It's been the direction of travel in all other solid organ cancers, and it's unlikely that prostate should be different once our technologies allow us to address the technological impediments. And the benefits that result should be considerable. But these are all assertions. I can't be sure that any of these are going to happen. The first, I think, is important. Currently, we treat everybody the same, irrespective of tumor burden, number of cause positive, location, Gleason grade. So they're treated at the whole organ level whether it be with surgery or radiotherapy. I think that statement still stands. And so this precision medicine, personalized medicine, will push us to treat everybody differently, something we call risk stratification. Therapeutic index we'll talk about a bit more. We've talked a lot about overdiagnosis, of which the main problem is overtreatment, and the main problem of overtreatment, other than cost, is the harms that the patient has to live with, usually for the patient's life. If there are no benefits to be had, because the patient wasn't going to, or ever destined to die of the disease, it's costs and harms that need to be mitigated. And maybe there is an opportunity here. We talked about the image-based pathway yesterday, and so our diagnostic strategy is going to change. And the first thing that we're probably going to elicit is location. We'll verify location, and then the conversations may be about how we use that location to inform our treatment. And the last slide of Thomas's radiotherapy first talk was about location, and that illustrates the radiotherapy community's response to this new variable that we've been blind to for 100 years. In other words, the dose painting, treating everybody differently because of the tumor that presents. So this is what's happened elsewhere. So when cardiac surgeons failed to adapt and change and thought they could operate forever, there was a dramatic change in the number of opportunities for trainees to go to. In the UK, 80 trainees who wanted to be cardiac surgeons had to redesignate as general practitioners because there just weren't any jobs for them. A more interesting and more recent transition is really in vascular surgery. And this is a blog, and this is somebody who wants to do vascular surgery. I'm led to believe that it's no longer a viable career option, mostly thanks to the cardiologists doing all the minimally invasive stuff. It's a dying specialty, question mark. Will it be a thing of the past or in the not too distant future? And then the response, cardiothoracic surgeons in the UK have contributed to their own specialty's downfall by not embracing new technology, interventional cardiology techniques. Current trainees in vascular surgery appear to have learned from your mistakes and started to demand interventional radiological training in angiography, angioplasty, EVARs, and stenting. And that battle could have gone either way. The interventional radiologists wanted to do it all. The vascular surgeons managed to keep it for their specialty by really pushing the training of their youngsters. So it's this, I think, that's going to present us in the future. This will be the first thing that we elicit in a man at risk. You saw these images yesterday, and it's really how we respond as a community to this new information. Do we become custodians and experts in imaging? Can we add value to this information so that we can either monitor this lesion, biopsy it with precision, risk stratify this man with great certainty, and possibly manage this lesion in a way that concords with the patient's wishes and desires. And that may include a tissue-selective approach, whether it be with seeds, HDR, cyberknife, ice, heat, electricity, injectables, or indeed magnetic nanoparticles. And all these are being proposed as we speak. And I think that's the challenge. And currently, I think we're currently a little bit behind on that. This is a real case. This is a patient that was treated in our unit in this modern manner, or new manner. And you can see the lesion up there. First thing that we did with a high PSA was an MRI. Many of you are doing this already, and the discussion starts there. This is the T2 sequence. This is the gadolinium sequence on T1. You can see the vascularity of the lesion high up there on the left, which obviously would have been missed on a standard truss biopsy. You can see just about the diffusion deficit in the same place. And on the long B, which is another form of diffusion scan, you can see the lesion up there. And obviously this resulted in a new approach. This man wouldn't benefit from a standard biopsy approach. You would miss it. And it was targeted, and it showed a relatively low volume, 5 millimeters maximum cancer core length, Gleason 3+4, 3 or 4 cores positive. He had an ablative technology. This happens to use electricity. I don't think there's anything particularly interesting about that, other than the technology was applied with information on location. So he had 4 needles placed around that, which resulted in 6 iterations of electricity over 10 minutes as a day case procedure, and that resulted in ablation of that zone of the prostate with non-perfusion, which is illustrated here on the T1 gadolinium scan at 1 week, and you can see it there. So that's where the tumor was, I think you'll all agree. And the preservation of prostate really is really quite remarkable. So in other words, everything but that area is entirely within normal limits. You see the rectum normally perfused, neurovascular bundles normally perfused, and indeed the capsule normally perfused around it. The only area I'd be concerned about is an increased amount of perfusion here, but this is probably an inflammatory reaction to the necrotic area. This is the coronal sequence, again showing just how you can preserve anatomy. There's the sphincter mechanism, you can see there, and the bladder neck, which remains closed, probably predicting that this man will keep his antegrade ejaculation, which indeed he did. This is the prostate at 6 months. I think if you didn't know the story, you would report this if you were a good prostate MRI radiologist as being a normal prostate. The only thing that might draw your eye is the scar tissue up here, which is not too different from the fibrostroma that tends to be associated with the anteroseptum. But essentially, a normal prostate. PSA's come down from 6 point something to 1.7 by just ablating the lesion in that area. And you remember on the long B, there was an abnormal signal, and he has a long B sequence now. This is a 5-minute sequence to elicit, you can see, no abnormal signals. So this man has no measurable disease in his prostate. So he had normal erections, normal ejaculation, drip-free, pad-free continence at his first assessment, and a PSA of 1.7 at 3 months, which shows a significant reduction. And the question is whether he is representative of other patients that have a selective approach to therapy. So there's no question that this can be done. There are many people doing it. There have been people doing it much longer than ourselves. And I think the question is, so what is reasonable to say to a patient who is asking about this type of approach in today's setting in terms of the evidence that we currently have, the evidence that we're missing, and the uncertainties that he will have to engage in as we go forward in the future, in the same way that the first patients had partial nephrectomy, or indeed breast lumpectomy, or indeed some of the new minimally invasive rectal cancer treatments that patients are having. Patients will give up quite a lot to preserve function. So I think the first question, and this relates to the evidence that we've currently got going forward, relates to the kind of safety of focal therapy. And I think we can be pretty emphatic about this. You don't need a randomized trial to show safety. You don't need long-term follow-up to show safety. So the case series that we currently have that have been put together now in a systematic review and published, I think demonstrate with reasonable confidence that this is a safe procedure. Focal treatment is much, much, much safer than whole gland therapy in terms of the general toxicities, low impact, a day case procedure, and also in terms of the genitourinary and rectal toxicities that we associate with other treatments. Is my decision likely to affect my survival? So is my decision to have focal therapy likely to compromise the number of years that I have left? Will it change the date on which I die? And of course, we can't answer this because we can't look forward into the future, but we can extrapolate from other studies which have made comparisons between maximum therapy and no therapy, and you know what's coming next. And that's a number of studies showing us that the overall risk to patients with a range of prostate cancer is going to be low. We don't know quite how low, but as you know, in this study, there was no statistical significant difference between prostate cancer or indeed all-cause mortality between maximum therapy and a very conservative approach to treatment. Focal therapy is not no therapy. It's not a conservative approach to treatment. Your aim is to eradicate all measurable disease in the majority, in excess of 90% of the patients. So it's very, very unlikely that we're going to be able to demonstrate any difference between surgery and focal therapy unless we have 10,000 patients. This was underpowered. Imagine how many you'd need to show that, and 15 or 20 years of follow-up. So I think the risk may be there, we don't know. I don't know what's coming in the future, but I think we can say to patients that the risk of compromising your survival is going to be low. Is my decision likely to affect my erections and continence? And increasingly we add to this ejaculation. The whole BPH market at the moment is all about ejaculation. All the new technologies are about whether they preserve your ejaculation or not. I suspect that in 5 years, when we talk about prostate cancer treatments, the ground will be on whether we can preserve wet antegrade ejaculation and preserve orgasmic sensation in our patients. And I think the answer to this is obviously yes. Tissue preservation, and that's the great discovery of the few years, does confer better functional outcomes than non-tissue preservation, and that should be fairly obvious. I think it's the studies now confirm this, and your choice of treatment, of whether you have the robot driven by a true expert or an ablation device, this is a HIFU device, again, has to be driven by a true expert, whether it confers differences in functional outcomes. And I think the answer is yes, and we just go to the literature. I know all of you have better results than this, but these are the results in the public domain that show that 20% of men, when asked in a trial formally by independent assessors, still have incontinence at 2 years, and 4 out of 5, 80% still had erectile dysfunction at 2 years. Now, all of you say this is ridiculous data. This is not representative of my practice, but it's certainly representative of Sloan Kettering's recent practice. 20% incontinence at 1 year. Differs by surgeon, but the confidence overlap. And I don't think any would argue that this was a bad centre, where they take quality control very importantly. Remember, this is done by Andrew Vickers independently and done through questionnaires. And again, identical rates of erectile dysfunction, 70% at 1 year versus the 2 years from pivot. Now, this is the average result that patients can expect. If they are lucky enough and resourceful enough to go to some of your centres, I'm sure that can be improved, but it's the average result that we are trying to improve upon. And really, it's whether focal treatment can improve on this. And I think there is evidence now saying that, done by experts and done very well, the application of energy to certain parts of the prostate, provided you stay to one side of the midline, can result in really extraordinary functional outcomes, to the extent that functionally the patients cannot be discriminated between preoperatively and postoperatively from a statistical basis. From a statistical basis, they are identical in terms of their ability to void, their ability to have erection sufficient for penetration. And this was really the first proof of concept in 20 patients. And this showed that all the patients, or 95% of the patients, had erection sufficient for penetration at 1 year. 95% of the patients had drip-free, pad-free continence. Only one didn't in this first study. And this resulted in a trifecta rate, if you believe in that summary statistic, of 90%. So 90% of the patients were free of disease, had drip-free, pad-free continence, and erection sufficient for penetration. Most surgical studies have a trifecta rate of about half that currently. And when men are reading that, that obviously informs their decision-making. None of the studies restricted the tumor volume on and these were hemiablation studies, so there was no limit in the number of cores positive, no limit in the cancer core lengths, but we did limit it to Gleason 4+3, and for this study, a PSA of 15. So there were tumors of high burden, this one occupying most of the peripheral zone on the gland on the left, which is typical. He had a hemiablation, which was the intervention required in this early study. And you can see the 1 week post-treatment MRI there. And then you can see things about 6 months later that the gland is completely normal on the right-hand side, but the gland on the left-hand side has disappeared. There's the urethra enhancing on this gland, and just a little bit of scar tissue just to the left. And it's this bit that we biopsy in these studies to see if there's any residual disease, which is not easy to do. It's fibrous, and it's quite hard to hit. And then came a second study in which we said, well, actually, hemiablation is quite a lot of treatment. Let's see what we can, identify all the disease we can and treat what we can. And that was the Lancet Oncology paper, which showed identical results, really. Many of these patients had bilateral treatment, so this explored the geography of what it is that we're treating in relation to genitourinary outcomes and early oncological status. Oops, I'm sorry. And you can see here, this is really a graph of recovery. So for these studies, we insisted that all men have had good functional a status at entry. You can see that there was complete return of urinary incontinence by 2 definitions, one at 3 months and one at 6 months. This is the drip-free, pad-free definition. So all men retained complete continence. So, 80% were continent at the 1 month evaluation. Erections dipped down a little bit. 60% of the men were continent at 1 month. At 3 months, 80% of the men had potency sufficient for penetration. And then it went up to 90% in this cohort. 95% were free of any evidence of disease, and the trifecta rate in this group was 84%. So in terms of medium oncological control, again, a little bit more imprecision, because we don't have much long-term evidence. This is a new technology, and we have to wait. And so we have to look to some of the earlier studies to get the kind of 7-year median follow-up of 4.1 years. And the oldest study that exists were from focal cryotherapies done off-trial, usually in boutique clinics in Southern California and Florida, that have been put together in this rather informal study in which 73 men that were treated in this manner by real experts, radiologists I might add, so Duke Barn principally and a few others, and these have been followed up by the USC group. So this was pre-MRI, these had very intensive biopsies and fancy ultrasound to try and specify where the disease was and where it wasn't. So obviously our ability to do that is much improved today because of MRI. But this really gives us some inclination of the long-term efficacy. I think what's important here is there was only 1 out of the 71 patients, 1 in-field recurrence that occurred within the treatment zone. Obviously the treatment zone with cryotherapy is quite large. It's usually a hemiablation or a hemiablation plus. And because of the difficulty with ultrasound, lack of MRI, multiple biopsies these men had, 11 of the 71 men had recurrences within the outer field area, so in other words, in the other lobe. They're not recurrences, sorry, probably just reclassifications. There may be some new lesions identified, most of which were low risk. And that's really the best we have at the moment in terms of the long-term outcomes. So it looks favorable, and I think the either reclassifications or identification of new lesions in the contralateral lobe is similar or less than you'd expect in active surveillance, given that a lot of these men had high-risk lesions in the treated lobe. Just like in the kidney, the question arises how you will monitor these patients. PSA has less utility, although it does diminish by quite a bit and does stay stable in the men that appear to be free of disease, but obviously there's a lot more to learn. And I think the answer here is that imaging, in the way that it does in the kidney, and indeed most other solid organ cancers, is going to be the way that we'll monitor the disease. And a normal set of images will confer freedom from disease or a status of no measurable disease, as it does in the breast, liver, kidney, brain, lung, indeed everything else, and that we won't probably pursue this with biopsies unless lesions developed. And I think it's probably the diffusion sequence that is going to be the most sensitive in the future. It's cheap, you don't need a doctor present, takes 10 minutes to do, and can be applied relatively frequently. You'll remember this guy that I showed at the beginning. You can see the lesion there, just I think on this projection, and you can see it absent there after treatment, and you might want to repeat this every few years or repeat it if PSA rises, or if some other marker suggests that recurrence may be present. And obviously you'll be using the same test to make sure that there'd be no new lesions in the other parts of the prostate, in the way that you would still do a mammogram on the untreated breast in a woman who has been treated for breast cancer on the treated side. There's a lot more. This is a rapidly developing area. There is a lot of evidence which is about to come out. We've just submitted our 3rd cohort at present, and we'll have to wait for that to be accepted and published. The European randomized study against active surveillance is fully recruited, and again, we just have to wait for the results. We're recruiting very rapidly. In fact, just finished the 140 patients index study. The study we're doing with Freddie Hamdi against radical prostatectomy is just going through funding. We're just responding to the referee's comments, and I suspect that will get funded in a pilot version, so we'll have a comparative study against another whole gland treatment. And the French study, I think, is pretty close to being finished. So there's lots of evidence that we will have, probably this time next year, that we can use to help inform our patients and reduce the imprecision and the uncertainty that currently exists. So I think this is, these studies are very easy to recruit to, very, very acceptable for patients. Patients value the combination of benefits and are willing to live with the uncertainties that we've exposed. I think we can say that these treatments are safe, well tolerated. There is no question about that in terms of evidence. Short to medium-term cancer control is good in all the studies that have been done formally and in some of the studies that we have that have been less formal. But obviously we have to wait long-term results, and all our patients go on to long-term linkage to death and to routine data collection, so we can track them over 15 to 20 years, or at least until they die. I think it must be one of the most fascinating areas in urology at the moment, in the same way that the dramatic change from when lithotripsy was introduced, or indeed when robotics was introduced, or indeed when laparoscopic came in. And this is probably the area that's most exciting and has most opportunity for us in terms of innovation and invention. But it's still controversial, and many of you will be feeling uncomfortable that this is not right, in the same way that the mastectomists did, and the same way that the nephrectomists did. And you're in excellent company, and this is Patrick Walsh telling me that he's very disappointed that a Lancet journal would permit the authors to conclude that these patients are actually free of disease, and for the authors, me, to fool the public into believing it. Laurie Klotz came to my rescue with a response to this, but in fact in this paper we publish all the results by all the definitions of cancer, and you can just read the ones that you want to. Things are changing very quickly. These are all areas in which some form of focal therapy or tissue preservation is happening, whether it be by radiotherapy, whether it be with ablative technologies. And if your unit isn't represented here, you might be concerned that your business will go elsewhere. And you can see that I couldn't have shown this map a year ago. Most of this has happened in the last 12 months. And it's very interesting to see young urologists come visit us to try and learn some of these technologies. What's less, or what should be more worrying for us, is that about half of my visitors are radiologists or interventional radiologists that's seeking to acquire these things. There's lots around the corner. I mean, Laurie Klotz has got some fascinating technology, intraurethral HIFU, which will use the MRI to control the dose. So there's all the skills that we require really are taken over by the machine, in which the dosage will be delivered by the machine, the temperature will be measured by the machine. There is lots around the corner. This is thermomagnetic nanoparticles, which you can inject into the prostate or indeed inject into the system, and then use MRI to drive them into the tumor, and then use MRI to shake the molecules to create the kinetic energy to destroy the cells. This is a fascinating space for the future. And indeed, I have to thank all my collaborators who have kind of helped us get there. Thank you very much indeed.
Thank you. Thank you very much, Mark, for this fantastic move into a new paradigm in the future. Is there any question? Yes, please.
Mark, I think MRI, multi-parameter MRI, becomes more and more standard in detecting the tumor, the disease. But do you know any study comparing the volume of the index lesion in multi-parameter MRI and post-prostatectomy specimen?
Yeah, there are two. One is in press, which you may not have seen, and another one's been published. And there are irregularities, right? So usually our imaging underestimates the full extent of the tumor on histology, and that's why we apply margin. So I think that occurs in all organs, and it would be a surprise if it wasn't the case in the prostate. What's interesting about the prostate is that we don't know which is the best sequence currently to estimate the tumor volume, and it varies. And it's interesting, and it may actually be telling us a lot about the tumor. So in some tumors, it's the T2 sequence, the anatomical sequence. In some tumors, it is the gadolinium sequence. So tumors that have switched on a a phenotype that attracts, so the angiogenesis phenotype might be the biggest one and correlate most closely. And in some cases, but usually not, it's the diffusion one, which tends to be less. So at the moment, the advice is take the biggest of the 3 sequences and use that, and then apply a margin. MRI will never, and no imaging platform will ever detect microscopic extension of tumor, which is why we apply a margin. What's interesting about the last decade is that our margins in all disease have got less as our ability to define the tumor has improved. So we've seen that in melanoma, penile cancer, kidney cancer, in fact, all the cancers, in fact, the margins are diminishing, and I think we need, obviously, more work on that. But I think 5 millimeters was probably adequate.
Okay, yes?
Yeah.
Front.
May I have a question in respect to the residual
Yeah.
disease, residual cancer? When I remember to cryotherapy Horst Zinker performed years ago, then he put the glands out afterwards, and in 70% he had residual cancer in this.
Yeah.
Have you made also the glands looking for, not only by biopsies after your procedure, also by putting out the glands?
Yeah. I mean, the residual cancer is a staging risk stratification. Is that what you mean? Do you mean in field? Do you mean cancer that evaded the treatment? Or do you mean cancer that we pick up on subsequent assessment?
No, cancer in the field you treat.
Okay, yeah. So there is no treatment that will eradicate all cancer. And currently, and some patients in all cancers will need more than one modality of care. We see it in breast, rectum, in fact, we see it everywhere. So the question is, what are the errors? Why are we failing to eradicate cancers? And I think each technology has a different list of failures. In cryo, it might be not getting down to -40 once or twice, and an island of cells can exist. It may be that some phenotypes of cancer are more resistant to certain types of injury and can recover being cold or hot or electrocuted. In HIFU, what we're finding is that focal therapy is much more efficient at eradicating tumor than whole gland therapy was, for obvious reasons. If you're applying a dose across a whole prostate for 3 or 4 hours, you're getting swelling and your original plan stands, so there are gaps that appear between your treatment. If you actually increase the energy dosage to a small area, as I think radiotherapists are starting to do, you can increase the efficacy of your therapy. But there will never, ever be 100% efficacy at eradicating cancer, and therefore the issue of retreatment arises. So in other words, the issue of cumulative toxicity. And the nice thing about some of these treatments is they can be reapplied again a second time, and indeed we've just published our experience of retreatment. It's an e-version now, if you want to look at it, and that's been looked at by an independent person who we gave our data to. And what I tell patients now is I can give you an 85% chance of getting you free of disease within the period of our follow-up, which is 7 years. There's a 10% chance that I will need to retreat you, and there's a 5% chance that you will cross over to some other form of treatment, whether it be surgery or radiotherapy or hormones. And that's our current data.
Yeah, Alexander.
Great talk, Mark. Most of the data are based on the index lesion, the concept that the biology would be driven by this largest lesion, and you've confined most of your patients to the Gleason 7.
Yeah.
So, provocatively, what prevents you, if you were to know what the lethal clone was and yet lots of markers just in the hallway as well, what prevents you from moving to the Gleason 8, 9, and 10? So, because for the time being, you're in Gleason 7, where many Peter and Evers would show that a lot of these patients will do fine no matter what, that the amount of patients that will die from the disease is actually really minimal. Yeah. It might take you 100,000 men to really show an impact, whereas the big money will be in the larger lesions, and where there is, given the mutational landscape of prostate, which is so complex, that's where you could hit some walls.
So the answer is reviewers. You know, when you're starting something new, you've got to get funding, you've got to get through ethics, and so we capped our risk, just pragmatically. What's fascinating, what's emerging, two things really. So one is MRI is identifying, and anybody that's doing MRI will know what I'm saying. We're identifying these very small, very aggressive lesions that I think hitherto we've been missing, because they're so small that if you biopsy them, you're going to miss them. They have the complete phenotype, so they're 0.2 cc's in volume. They shine at you like a beacon. They've picked up a blood supply. They have a very low ADC value. In other words, there's a lot of cells there, and they proliferate. And I suspect these lesions are the interval lesions that we have missed traditionally. And when you stick a needle in them, they're very high grade. Part of that's artifact, because there isn't much. And if they got pattern 4 dominates, and then it's very easy to apply an 8. But they are a new lesion that I think we have missed before. And it may be that these lesions are almost not treatable, that they develop and progress so rapidly and metastasize so quickly that, that there's very little we can do. But MRI gives us an opportunity to identify them. Treating them focally is easy. If they haven't metastasized, the actual technical challenges are minimal. So I think you're right. I wouldn't cap it. I would cap it on location and volume and position rather than Gleason score in the future.
Mark.
Okay, two questions I have. You showed us data on no evidence of disease recurrence, and how do you define that? Is there something like an accepted standard that we have for radiation therapy or radical prostatectomy? First question. Second is, if somebody comes to you now as an expert for focal therapy, is there something like, what do you offer somebody who would like to have? Is it a high focal HIFU? Yeah. Is it two-cut, or what is the kind of a standard, or what is your approach?
Right. So we don't know. So I'll answer the first question. So I don't know what the right oncological outcome is. So in all our papers, we publish everything. So what we're trying to do in focal therapy is to treat men who need treatment. So in other words, men with clinically significant disease, and you've seen we have various definitions of that. And what we try to do is to put them into a status of low-risk disease or no disease. I can't tell the difference between low-risk disease and no disease because our tests are not sufficiently reliable. You know, look at the REDUCE study, look at REDEEM study. The tests vary. So that's what we're trying to do. So we publish everything. So anybody that has any cancer afterwards is published, but I would ignore 1 millimeter 3+3. And we have all the patients that are free of clinically significant disease, which is the primary objective. And then we also publish the status of no evidence of disease in terms of no rising PSA, absence of signal on MRI, and negative biopsy. So you can make your own conclusions on that. Second one, increasingly, this isn't about which energy, and this is about applying the right energy source to the right patient. So if the tumor is very high up, as I showed you on the first one, I can't reach that with HIFU because my HIFU machine has a 4 centimeter focal length. But I can reach it with needles because I could biopsy it. And so he got electroporation. HIFU is our workhorse. It's what we use every day. But we tend to use that for the peripheral zone lesions. If we've got a T3A lesion in a 78-year-old who wants treatment and can't have radiotherapy, doesn't want radiotherapy, we'll use cryo. You know, so we'll and I think there are new treatments coming through. You know, the injectables look very interesting. There are 3 companies looking to start phase 1 studies by just injecting these tumors with anti-apoptotic, pro-apoptotic agents, or agents that induce cellular necrosis. So I think it's tailoring it. I think this is a specialty that's emerging, which is I think is behind your question, and you have to tailor the individual to the treatment to the individual.
Okay. 2 last questions, one for Peter and the other one for Professor Hulan. Yes?
Mark, great talk. As usual, you're following the oncologic principles, proving safety first. You're now tripping up on the efficacy question, which is what Pat Walsh challenged you with just now. So how are you proposing going forward, taking Alex's comment into play that sample sizes are huge for low grade? If you don't start tackling the high grade tumors soon, because that's where you're going to prove your efficacy, we'll just be back in the realm of mass plus urologist equals operation. The mass this time is MRI rather than palpating something.
So the majority of the patients we treat are Gleason 7. I didn't show you the slide, but I can if you want. So we don't treat low-risk disease. Gleason 3+3 doesn't get focal therapy in our institution. So you have to have yellow or red disease to qualify for our latest study. And we want to put you into green disease or no disease. I don't think the world... So if I put in a proposal to treat Gleason 9 or 10, I think it would get rejected today. And obviously, off trial, we do it with full consent, etc., and with long-term follow-up. But they're highly selected patients. But the opportunity exists because we can catch these high-grade tumors early. And I think that's where the real opportunity arises. But there aren't many of them at the moment. But no, focal therapy is not for low-risk disease. I don't think we should be diagnosing men with low-risk disease. So I think, you know, and then obviously surveillance is going to increase, and surveillance is going to go into secondary pattern 4, and many of these men with lesions that I show you, first thing we do, get up the MRI, and anybody that's been in our clinic, and there's several of you that have, the first conversation we have, well, there's your cancer, you know, what should we do? We could watch it, or we could biopsy it and see what happens. Many now we're just watching, you know, I hesitate to say this, without a biopsy, and they remain stable for quite a while. So surveillance is going to change, surveillance is going to increase, our biopsy is going to be judicious, I think, and then there will be an opportunity for focal treatment, but there will always, always, always be an opportunity for whole gland therapy in the way that 1/3 of women still require mastectomy, and a large proportion of patients still require nephrectomy. So where exactly those demarcations will lie, I don't know.
A very short last question.
No, it's not a short question. Although I'm very much impressed by your presentation, your work, no question about it. I will bring up a point from a very old-fashioned surgeon. Looking to our specimens, for the patient who we selected for radical prostatectomy, 86% are multifocal, number one. And the distance from some tumors, what I showed yesterday, to the nerves, to protect erection, sometimes really is less than a millimeter, and I cannot imagine that you can preserve it then heating that at that point and 1 millimeter apart, preserve everything. And molecular biological studies show what was mentioned before, that it's not clear that the index tumor is the worst one. Maybe it's the other one. And in addition, we did biopsies from the so-called normal tissue, and you see some fingerprint of cancer in the normal appearing tissue. All arguments against focal, it's different as in kidney cancer. In kidney cancer, you have a unifocal tumor. The rest of the kidney is more or less normal. So there are so many differences, and I put them all together in the argument to do a radical prostatectomy.
So if that's a short question, yeah, I'd hate to hear a long question. So I think your observation is correct, but I think also there's an increasing recognition that all cancer is multifocal and that multifocality doesn't matter. In all the natural experiments, lung, where there's extraordinary amounts of multifocality, thyroid, breast, I mean, the breast is a revelation. You know, that intraoperative radiotherapy is equivalent to whole breast irradiation in terms of local recurrence rates, just knocks the multifocality story out of the window. It's not about multifocality. These breasts are multifocal, we know they are, and that was the justification for radiating millions of women for the last 10 years. But in fact, the latest data suggests it's not about multifocality. Most small cancers are not destined to progress. I think that's increasingly being shouted out by most of the, you know, and in fact, it's like a weather report. So it's like predicting the weather years in advance. Most of these small cancers probably may actually go away, as we're seeing in the Canadian breast cancer series, or indeed just persist, that they never acquire a phenotype or a genetic change that allows them to invade and become worse cancers. Even in lung cancer, lung cancers are full of these tiny lesions that don't progress. You know, the most lethal cancer there is, apart from pancreatic, probably. So I think there's a lot to learn about multifocality. And if we treat all cancer, if your objective is to treat every cancer that's out there, we need to treat all the men in this room. You know, to follow your logic, you have to then treat. And of course, none of us believe that. So there is a type of cancer that we need to identify that merits treatment. I'm not pretending to know what that is, but I think, you know, selective therapy will allow us to explore that.
Okay, thank you very much. I think